You can start whenever you feel like you're ready.
Okay, I think I'm gonna get started, Eric. So I need to first switch to my screen here. Hello, welcome. Hi, this is Yue Dong on behalf of the Society of Simulation Healthcare Healthcare System Modeling and Simulation Affinity Group. This is our first series of the webinar we're gonna hosting in the next couple months. I just give you a little background of this group. So this group is formed in 2013 in January in Orlando. I think 30 plus of the society members gathering at the conference room there. We want to form a group of this small group, affinity group, try to focus our efforts on computer-based modeling and simulation. So as this is there's a couple slides I want to share with the group. Because simulation is one of the representation of the system. We think, beyond the education and training, there's other capability we can use in simulation to achieve through system integration and particularly in the computer-based modeling. And this is our mission, from the group, try to develop and use modeling simulation, computer simulation resources with the specific system engineering-based approach to design and evaluate system solution that will improve patient safety, quality of care, and cost effectiveness in healthcare. And talk about safety, I think I want to emphasize, safety is a characteristic of the social technical system, including people, including technology, process, organization, and external.
Ray, I'm sorry to interrupt you in the middle of your talk. I think you are sharing your PowerPoint master screen and not your slideshow.
Is it right? You cannot see. Okay.
There we go.
Interesting.
Okay, now I'm seeing more slides. I apologize. Please go on.
Okay. You see the full screen?
I'm seeing it as individual slides, as your open PowerPoint file, but it seems to work enough.
It's working enough. Okay. There's some technical issues. Apologize, but a couple more slides. I think this is talk about the multiple approach, addressing multiple entity in this whole healthcare systems, and computer is a very important tool. It's been been advocated by multiple different groups. Looking at one of this paper back to 1992, almost 20 years ago. So I think more recently there's several other major paper published. National Safety Foundation talk about how to using computer-based simulation try to advance engineering and science. More recently, last month, there's a couple major reports just released, talk about how to leverage system engineering approach to improving to provide better care and lower the cost. I think we think this is in the right time to pursue this direction. Using different tools, from engineering community. So we are here to try to learn from others and how to helping healthcare transformation. And today we are very glad to have our first speaker. Let me introduce the speaker today. Is Dr. Eric Goldlust from Brown University. Let me switch to you, Eric, just a second here.
Okay, very good.
Eric, we know it's been since about 2 years ago we went at the SSH meetings. He's a assistant professor from Department of Emergency Medicine from Brown University. He has been using computer modeling simulation to try to design, analyze, and workflow in emergency room setting. And so I think, Eric, would you mind to start introduction of yourself, and then we go from there?
Sure. Thank you very much. I will just launch into the lecture here, and my introduction kind of comes while people are staring at my disclosure slides, which otherwise are useless. But good evening, everybody, and thank you for attending, and thank you for your time and attention. As Dr. Dong says, my name is Eric Goldlust, and this represents the first in this lecture series by the Healthcare Systems Modeling and Simulation Affinity Group. The topic, as he said, is going to be discrete event simulation, which is the focus of my research, and how it's used in planning and evaluating clinical operations, with a focus on rigorous methods for operations research in particular. So I have no financial disclosures. I'm operating as an independent CML. I do refer to commercial simulation software, but this is not to be considered an endorsement of any particular product. My early studies were in engineering before I continued studies in medicine, public health, and epidemiology, with a stint as the founding director for 3 free dental clinics, followed by residency in emergency medicine, which incorporated essentially an internship in administration. And now, as he says, I'm the assistant medical director of initial exposure to systems engineering was at least 3 extremely varied careers ago, but I still draw on that experience, and I currently believe that a systems approach to medicine, and in particular the use of DES, holds a lot of promise for healthcare. But that is my personal opinion and does not represent any department, hospital, or organization with which I'm affiliated. All right. Done with the boilerplate, I think. So here are our objectives today. We're going to describe what DES is and contrast its strengths and limits with other methodological approaches. We're going to discuss how DES can enhance the efficiency and performance of healthcare systems. We'll describe how to build an effective DES model and how to validate it. And we'll talk about a couple of examples of what I believe to be rigorous DES research and how they demonstrate useful and potentially generalizable analyses. In other words, that they speak to departments outside. This is a new webinar series for SSH and for the Affinity Group, so we figure our audience is still in flux, and I made the assumption that most of the audience is really new to the ideas of systems engineering in medicine and to computer simulation compared to more traditional mannequin-based sim, but I realize that everyone is coming at this from different backgrounds. But I will start with a thorough general introduction to DES, covering why DES is important, what it is exactly, and what it's used for. In the middle of the hour, I'll build on that, describing why DES may be the superior method for certain kinds of research questions, and the nuts and bolts of how to design a study, build a model, do the work. And then in the last 10 minutes or so, I'll cover the general history of DES in healthcare, focusing on a couple of articles which not only demonstrate how a model is used effectively, but reported effectively and convincingly. And I'll have just a minute or two left over at the end to cover a few caveats about DES and known pitfalls in DES studies. I'm hearing a few people in the background, so I think this is a good time for this housekeeping slide. This talk is being hosted on Google+, but direct access is limited, and other people can watch live on YouTube through this link. You'll probably want to screenshot now because we're not going to linger on this slide. If you have questions, I'm going to ask you to enter them as a chat on Google+, or if you enter them on YouTube, we will be forwarding those along to Google+, so I will see those at the end. You can also call in the number shown and type in the PIN number, and you'll join a group. And again, I'll turn that on at the end so I can address questions live if there are any. So try to remember what slides we were discussing because we just won't be able to discuss everything live. There's too many lags involved. All right, that means that if you're listening with audio, please mute your own microphone. And with that, here we go. So what is DES? Here's why you should care. In short, DES is a high-powered tool for studying your clinical operations that goes well beyond those of regression modeling and queuing theory. I'll discuss why I believe DES to be underutilized in healthcare and why I think it holds promise as a ripe field of inquiry into operational practices. Most operational changes are still made on the basis of expert opinion, which generally means whoever's directing the department or the clinic at that time. But I think we all agree in those positions that it would be very helpful to have a means to test whether a change to your operations would work before investing the time, money, effort, jerry-rigging, malpractice that it takes to get it done before realizing it was doomed to failure in the first place. DES can do just that. It's generally more effective to simulate a large-scale clinical process on a computer rather than a real-world or a tabletop sim. You can control all the variables, and you have all the space you need, virtually speaking. Moreover, from a research standpoint, DES can be used to screen hypotheses and generate prelim data, basically to demonstrate proof of concept that an intervention may work. That alone may be worth the price of software. So here's how DES is used in the healthcare industry. Predominantly, DES is a tool to assess and fix problems in your clinical setting with patient flow. It allows you to cast a cool, objective eye on your department's operations and see where the problems are. So for instance, with DES, you can find and fix the bottlenecks. you can quantify the effects of those bottlenecks and determine what needs to change and by how much to achieve a particular objective. You can improve crowding. For me, it's particularly in the ED, but it works in crowded settings elsewhere as well. By using the simulation as a safe testing ground for possible solutions and hammering out some of the kinks before you hit the ground, and so on and so forth. You can optimize staffing of your department, point at which you have diminishing returns. I'll give you a good example of that later on. And so on and so on and so forth. There are many, many uses for this, but we'll start with those. Now, to be fair, this is not news. But as an industry, we're a little late in adopting it. It's not a new technology. It's really been used in other industries for 30, almost 40 years now. But like many IT advancements, healthcare lags way behind in this regard. A lot more has been done since then, first in emergency medicine, then the OR, the ICU, disaster management, and so on. And there's still a lot more work to be done. There are countless problems which can be addressed with DES. The peer-reviewed literature is the tip of the iceberg. Nobody's surveyed to see who's actually using DES, but it's definitely out there as a tool to develop, screen, and recently even quantitatively test hypotheses. That's my particular area of interest, and I'll shamelessly share some of my work later on. But frankly, I feel it's time we were all using DES, both in operational practice and in ops research. And apparently, the President's advisors agree. Dr. Dong indicated this link as well. The White House published online this report calling for coordinated efforts to apply systems engineering methods for cost containment and quality improvement in healthcare. So that's, some kind of endorsement. All right. So if we agree that DES is a useful tool, what exactly does it do? What do you do with it? Well, it's a means of modeling and visualizing operational practices, most commonly using one of a number of proprietary computer platforms to generate a model which looks like and acts like your clinical setting. It's capable of modeling the complexities and interactions within and beyond the department, and therefore can be used to assess inefficiencies in the process that you just can't determine by eyeballing it. So, for instance, if you run a grocery store with a dozen checkout lines, and I'll tell you, sometimes in the ED, that's what it feels like we do a lot of the time. You can use DES to answer questions like, how do you know when to open another checkout line? Should you put Alice in the express lane and Zeke in the regular line, or the other way around? You apply that to the hospital, it might be, how many med-surg floors do you expect to open on an average Monday night? When you call in backup, how do you manage hospital resources in a mass casualty disaster? And so on and so forth. Same kind of question, different setting. So drilling down then, what does the model look like? What's it made out of? Well, at its core, it's a bunch of logic. It's a set of rules that lets you think of time in your department not as tied to the clock, but as a sequence of events which trigger other events, and so on. This is, of course, complicated. I did see a great paper once showing how you could do this in Excel, but in general, you're going to want to use modeling software. But we'll come to that later on. In a DES model, time passes from event to event rather than modeling every single minute implicitly. Anything that changes the state of the department or a relevant part of it, like a patient or room status or whatever it is you deem important. So each bit of logic is triggered, as the name suggests, when a particular discrete event occurs. And that event means that a resource is acting on an entity at a location. What does that mean? Well, those basically are the players involved in a model, and here's what they look like. So an entity is anything upon which work is performed. A resource is anything that performs that work, and a location is pretty much what you think it is. So an entity, for most DES models in healthcare, would be patients, but it can be anything that you're doing work on. It depends on what you're looking at. So for instance, x-rays are something we do work on. They have to be shot. They have to be read by a radiologist. They have to be interpreted by me as an emergency doc as well, and by primary care docs later on. Charts also have to be written. So those might be considered entities depending on your clinical problem. Resources, again, are those things that do the work. And nurses and techs certainly do a lot of work. The lab is also doing work on your behalf, processing specimens. That specimen, in turn, may be an entity. The CT scanner might be considered a resource because it's doing work on a patient to obtain a CAT scan. And again, this depends on your clinical question. And a location, again, is pretty much what you think it is. It's anywhere you're doing stuff. But keep in mind, this could be a virtual location, like a PACS system, is where the images all exist online, but it's a place where the X-ray lives and where that work is being done to have it read. So that might be something you modeled. So this in turn triggers another action. When an event occurs, it triggers another event and another event and another event. So either something changes, a state variable of your resource or entity changes, probably of your entity. Something moves, so from one location to another. Or something happens, a resource. If you're having trouble relating this to your normal way of thinking of patient flow clinically, just think of a whiteboard. In my ED, a patient arrives and the information gets put up on the board. A nurse picks them up and updates the board. Then the doc sees them and updates the board. They order bloods and a UA and a CAT scan and they update the board. But the CAT scan might have to wait until the creatinine comes back and the urine pregnancy comes back. So first, the nurse has to draw the blood. Then the patient has to give us a urine sample. And if they take too long, I might have to order a liter or two of saline or a straight cath if I'm really feeling mean. And then we get the sample, and then it gets read. And if it's negative, then I get the CAT scan. And then we get the read. And if it's positive for appendicitis, then I call surgery and get the patient admitted, hopefully. Point being that none of that is tied to a clock. It's a sequence of if-then events and probabilities that it might happen one or the other. DES is just a way of formalizing that. Not typically to that level of detail, but you get the idea. So another major advantage of DES compared to simpler analytic methods is that DES software packages incorporate a graphical interface. While it's not strictly necessary or even scientifically important, I guess I'd dare say, except as a debugging tool, the visual interface gives your simulation real power in the real world. So imagine you're talking with a hospital administrator, maybe from another department than yours, and you have to discuss your process. Imagine how they're going to respond to something that looks like this as compared to raw data. You're going to have a lot more impact that way. And I've had that experience in my hospital, going to my administrators. My hospital's nursing and quality officers really responded to something that they could recognize visually above and beyond the sheer data that I was showing them. So there's real power in that. Here's an example of what a model looks like. Now, what follows is not an endorsement. It's simply a good example that I had to show you. It's an excerpt from a training video from MedModel, one of the simulation software packages I use, produced by ProModel Corp. And I think I just said that, and here we go. All right, so let's see if this works. There we go. Okay, so this is just sort of a sample model of a hospital. And at first glance, you can even tell almost exactly what's going on. Ambulances are arriving, and they're dropping off patients that arrive red for some reason. And just by picking them up, their status turns into yellow. And they're brought to one of several different rooms. It looks like they can be taken to 105 or down the hall to 101. I don't know what those rooms are. That really is the purview of whoever made this model. But they've done us the favor of including icons, which you can use in DES, just to sort of give you a visual idea. Mentioned these stakeholders quite a lot in this talk, can recognize exactly what's happening and where, and they can tell you if the model passes the sniff test, if it makes logical sense. That's what we're going to call face validity. You can see here the patient's being taken immediately to the CAT scanner, it looks like, which is a service I wish we provided in my ED, but well, anyway, you get the picture. This is what these things look like. All right, so now that we've covered what DES is and what context it's useful, let's talk about the range of investigative tools at your disposal in systems research and when DES may be your method of choice. So if you're considering how to assess changes to your clinical operations, you've got to start with the basics. You can experiment with your actual system or a model of some kind. Any kind of intervention in the real world is likely to require heavy costs, time, money, and effort. You've got to devote resources to the change. You're going to add and shift around staffing. You're going to change the supply chain to match your new service line, and so on. It is, in short, complicated. And I can't stress this enough. The costs of a failed experiment are long-lasting. If you try something and fail, your department is not likely to want to try again. They may well sandbag your future efforts. So perhaps it isn't always wise to start with an untested experiment in your real department. And that means using a model of some kind.
Hello, Eric? Eric? Hello, Eric?
Method, and that's where computer simulation comes in.
So, hey, Eric?
Yes.
I think there's a broken, because maybe the connection of issues.
Oh no, what's happening?
I don't know.
So now you're just seeing me. Hi there.
Yeah.
All right, let me try that again. Let's try the screen share.
Yeah. The same slides. Yeah, number 3, the item number 3 again.
Are you seeing the slides now?
Yes.
Okay. All right, good. So just to show you that last slide, in case you missed that, just so where everything fits in, you can see there's experimenting with the actual model or the system model. Actual system or the system model, physical versus a mathematical model, and from there, analytical solution, things along the lines of regression or queuing theory, and computer simulation. Continuing from there, you can models and dynamic models. DES is good for modeling processes which are dynamic, meaning that time evolution is important. Things change over time. Static forms such as simulation, like Monte Carlo simulations, can represent how your system works, assuming that nothing and your contingencies of care. But what if you have an OR that has different schedules by the time of day, or a scanner you can only access from 9 to 5, or an ER that sees a steady wave of patients that varies by hour of the day, day of the week, season of the year, and so on? If your chair changes in any way over time, consider a dynamic form of simulation such as DES. There are other other dynamic methods that tend to be more complex, like systems dynamics and agent-based simulation, in which patients and other actors in the simulation can interact. That could be useful if, for instance, you wanted to see how a flu epidemic travels through your hospital. So not to take anything away from these, but by and large, DES does appear to be the de facto standard at this time and effective for most clinical applications to date. Other things to bear in mind about DES, it is stochastic, meaning that some of the state variables, the things that describe your based on the probability that somebody walks in the door with a certain complaint or a certain condition. And they're discrete, meaning things happen at a particular time. There's a moment at which the patient goes to your CAT scanner, comes back from your CAT scanner, has the scan read, and so on. All right, so how do we actually use DES? Here's a simple 5-step method. I come from a discipline that likes 5 steps to keep things simple and straightforward, and I think it works for this particular application. You're going to formulate your question, define the process you're modeling, get your data and fit your data distributions, put them together to construct and then validate your model, and then finally you run your experiments. So let's take it step by step. Formulating a research question means having a good question. What's a good question? Well, it should be specific to your department enough that you're going to use your answers, but it should also have some applicability if you're going to put it forth in the literature, because it has to apply to other places. It can limit the scope of your model, but again, if you do this properly, it should find the balance of being applicable where you are, but also applicable elsewhere as well. We'll talk about that sweet spot later on. It can be a limitation of DES. It's important, even at this stage, to involve your stakeholders. By stakeholders, I mean anyone who has reason to benefit from this process of model building, meaning your department's management and operational leadership, frontline staff who are going to have things to say about whether your model is accurate or not, and may have even suggestions of what to change. It'll help you establish your scope, your objectives, the feasibility of your intervention, costs, and the timeline involved. This is critical for implementation success. You're going to clarify the metrics that you are going to use to assess how the model performs, things like length of stay and for what subset of patients, left without being seen rates maybe in the ED, utilization rates of your clinic. And you want to think at this stage about what your secondary outcomes are. Anticipate what your team are going to want. And again, involve your stakeholders so they can tell you. Then you define that operational process, and that means generating a preliminary model. What in the business world would be called a process flow map, in the computer world would be more akin to pseudocode. For a really complicated model, such as the one that I've built, I've built what most people would call an excessively complicated model of a very large emergency department. So complicated that we had to resort to the use of SysML, which is a markup language traditionally used for other purposes to define the process and use that as sort of the pseudocode from which to generate a model. But at any rate, you're gonna have something that looks a little bit like this on screen, where you have steps and decision points where you may go to one point or another depending on some particular decision. It'll help define who the relevant entities, resources, and locations are for your model. And again, you want to keep it simple if you're going to want to make sure that this has some applicability. And once you define your interventions and your assumptions, that'll tell you what the pieces are that you do need to specify and don't. You may be able to lump things together, in other words. The availability of your data may influence the question that you're able to ask. There may be some data that you're simply not able to get from your hospital or from other departments you interact with, and therefore you may be stuck relying on expert opinion or making it up. But if you have your stakeholders involved early on, you'll have more of a clue what information you'll actually have available to you, and you'll be able to keep the model accurate even at this stage in the game. You'll be able to maintain verisimilitude. I confess that this was merely an excuse to use the word verisimilitude in a lecture. Let's move on. Okay. So the next step is to actually get your data and fit your distribution. So when you're gathering the data, consider the source. You may be able to, oh, I'm sorry. That's an overly aggressive scroll button there. There we go. So when you're gathering your data, consider the source for your data. You may have some previously published information about how long a particular process takes in the real world. Probably not. These things don't tend to be out there, but hey, feel free to look. You are more likely going to be able to abstract from your information system if you have an effective information system. But if that fails you for the sort of thing that you are looking for, you may have to do time motion studies where you're actually physically in your ED seeing how long these things take. You can have an administrative assistant sitting there and clocking how long it takes to place an IV, to get a patient moved from one room to another, that sort of thing. You can also use RFID tags. So radio frequency ID tags are used increasingly in departments and hospitals. You may have this stuff and not know it. Happened to me. Turns out we had it in our hospital. It was even in our ED, and nobody was really letting us know. Fortunately, that has changed. But these are very good at tracking people and things that are moving and may be very useful for this sort of work. You may involve benchmarks for care from JCAHO or from other regulatory agencies, particularly for your future states. That may help define what your outcomes are going to be as well. Things such as desired turnaround times for your clinic visits, door-to-balloon time for the cath lab, that sort of thing. You're going to clean your data, meaning if you're pulling this from a source you don't trust, let's get back here. Cleaning your data from, if you're getting your data from a source you don't trust, like your information system, you need to make sure that the set of data you're looking at actually seems to represent the data you think it does. If you start looking at values that look impossibly low or impossibly high, that's a reason to take another hard look at it. So you might handle extreme outliers because that may skew the shape of your data too. that brings us to fitting your distribution, fitting your data to data distributions. This is the thing that gives the random element in your model. You can use some standard fitting software, some of which gets bundled with logical distribution. For instance, if you have a random constant, random set of arrivals that does not change over time, you might use a Poisson distribution. Weibull and normal distributions might be more appropriate for other care processes, and so on. Also, make sure that you've got all the data you need. You should be able to match everything you're gathering to a different step on the map. If you have an extra step that does not have data that you collected for, then you need to figure out how to gather that data or estimate that those data. You may have also defined your start and endpoints wrong. You may have left out a subprocess somewhere. So that's doing that in real time is a good way of making sure that your model is going to end up which is to say making sure that the model really looks like it should, represents the real-world process. That comes into play more here in step 4 when you actually build and validate the model. So you have a few choices to make when you're building your model, and these should actually come early in the process, but they don't come into play really until step 4. Things like, what software language are you going to use? There are some standard packages out there, things like Arena, AnyLogic, Simio. You saw an example from MedModel. If you're really, really good at programming, you might use something like Visual, C++, or Java. I personally don't recommend that because it won't be as portable, and it'll be harder to manipulate by someone else later on down the line if it comes to that. There's also the question of who's going to do the modeling. Again, if you're really skilled in this arena and have the training, it may be you. But I suggest having someone independent of the clinical environment who is the modeler, because they have a different perspective on it. And I think having a team that includes a dedicated modeler and clinicians to construct the model really is instructive in helping you understand your process. I've done this because, well, I don't do any programming anymore. That's been many years now. And working with modelers has been really helpful to help me understand. If you're really good, you'll be able to convince your department or your hospital or your clinic system to hire a dedicated modeler, which I think makes more financial sense. This is something I think you'll find a lot of use for again and again. But for the early steps, you may be stuck with a subcontractor, which is also effective, but they're not as invested in the process, and therefore they may have results that are idiosyncratic and make sense to them and not to the next person you work with. You then take the processes and their probabilities and data distributions and plug them in and see what the model looks like. Throw it past your stakeholders and see if the process you've generated and that, that visual that you saw from that MedModel video looks like to them what it's supposed to, and that people are actually moving where they're supposed to, and techs are going where they're supposed to, and nurses and providers and patients and so on. Then you do some test runs, and this is what I would call internal validity, or in the computer science world, validation and verification. It's not only debugging, but also testing of the process by sending single entities through. So you send a single patient in, a very slow day, and you're sending just one patient, and watch where they go, and make sure that that one patient doesn't do anything crazy, and do it with another patient, and see if that patient, who again should be probabilistically different from the first one, also acts accordingly and doesn't end up going anywhere crazy or holding up anywhere crazy, and do that again and again and again. When you're done with that, you do what's called stress testing, where you try to overwhelm the model. That means you send in a bazillion patients, and you make sure that the model doesn't just break on you and suffer from exception handling. You should see people pile up, because that's what would happen in any setting if you had a bazillion people show up. You would have lots of queues in the waiting room and in other places. So that's okay to slow down on you. So once you've got a model that you believe is working for you, then you can design your experiments and analyze the performance. You need to have some specifications for your experiment. You want to know how long a run you're looking at. You don't want it too long, because over time you may start to accumulate errors that you don't run it for many, many months. You may start to see patients accumulating in a location you don't expect. You want a warm-up period to try and pre-populate your hospital department, although if you're modeling a clinic that closes down at night, then that may not be necessary. And decide on the number of simulation runs you want. it's kind of arbitrary. It really just depends on how much time you want. You can run thousands and thousands and hundreds of thousands of patients through, and typically I do. You want to choose what your input stream is going to look like. I liken this to the difference between direct matching and group matching for experimental or observational studies. So things like direct matching would be you have a simulated cohort and you send that exact same set of patients at exactly the same time into the system, and then you do it again, and then you do it again, and then you do it again. So it really is the same virtual patients going through. Whereas group matching would be, well, you have a simulated cohort that was generated by rules. So by, there's a certain case mix in terms of their complaints or their gender mix or their their triage severity level, whatever it is that you deem as important, and how you're going to vary those patients or whatever entity rules, and therefore be essentially group matched, but won't be the exact same patients at exactly the same time. Then you can decide on your output variables. You should have decided that early in the process, and how you're going to handle errors and outliers. Deciding a priori what constitutes an outlier really adds robustness to your study, as with anything. Then you finally run your experiment. That actually will take less time than all the rest of this by far. You're going to analyze your output data, present and use your results, but at this stage of the game, you want to report to your stakeholders and see if your results make sense as well. At this point, if you really have involved your stakeholders in the game, including your heads of operation, they're going to want to use your results. And therefore, they're going to want to put these in place in the real world results to compare. That's a good indication of whether your model was in the future. That's not done very often in studies, and as I'll discuss in a minute, there are a few good examples out there that do that, and I think that's one of the great frontiers in DES research. So speaking of that, and with all those nuts and bolts, I want to change gears a little bit and talk about what has been done with DES, talk about the literature base for DES in healthcare operations research. The first articles on this really date back to 1975. This is the first proposed article for DES in healthcare, and it was proposed in a socioeconomics journal. Other industries have been using this long before us. It wasn't until 1989 that we actually did something about that, and and that and feel like this stuff belongs to the emergency department. Well, it's not true, but it is true that we were there on the ground floor. So there. The second. And so big delays here. Again, in healthcare, we're just slow to adopt these sort of things, but it was a good proof of concept model connecting the ED to the ICU, and many other studies were done in the following decade and beyond. And as an example of some of the problems that were looked at, and these definitely overlap, but there are studies which optimized patient and staff scheduling, compared alternate triage processes. The Day article is one that we're going to discuss in just a minute. Whoop, let's back up. Sorry, that darn scroll button. Okay. It's also been used to analyze and visualize patient flow in a number of settings, including the ED, but also in ICUs and ORs and so on and so forth, to optimize bed capacity in intensive care units and beyond. The articles by Hoot were really seminal in the use of DES to forecast what was going to happen in your department in the near future. And in my field, emergency, DES has been used to assist in the design of clinics and adjunct clinics, things like the hospital pharmacies, such as this Reynolds article. It's been used to help see what can decrease boarding of inpatients in the ED and elsewhere, to study interactions between providers. Again, this is the sort of thing that may be more suited to agent-based models. Assist in the process of clinical trial design. This article by Barrett was one where it was used to aid in allocation of patients to research studies in a pediatric oncology ward where the actual condition may, excuse me, really for orphan conditions where the number of patients are too few, additional randomization. If you want a good review on this, though, I suggest this one. There's a couple of others out there, but this is a really solid one. It's a couple of years old now, but the Schoonell and Pidd article really reviews and categorizes articles very well. So here's an example of what I feel to be good reporting practices. I'm obviously very biased. I am the last author on this here, but I'm going to present it anyway because you can't stop me. So let's talk our way through this 5-step process I told you. First, we formulated the research question. This was done at a VA health center, level 3 trauma center with 20,000 visits, which is pretty small. And the intervention actually came out of the question that was asked. The question was asked by use the metric of the number of patients who leave with whose length of stay is greater than 6 hours in ED. That's their metric for success. For whatever reason, that's what they choose. And they wanted to reduce that at this VA. So we used DES to screen through a bunch of hypotheses, not really shown here. And the DES suggested that the best bang for our buck was to move our physician and mid-level provider from the fast track area to the triage area and discharge from triage whenever possible. And I'll show you what that looks like. So here's our predefined operational process. This is the before situation. There's a pre-triage area, a triage area, and treatment areas within the department. Patients are pre-triaged. A few patients to be in the ED in the first place, or they were better seen by clinics. Some of them were taken directly to treatment beds in this little bypass track that goes through the triage area. Those are the ESI 1s and 2s. Those are the higher acuity patients. And then the lower acuity patients were registered, sent through triage. Some of those were sent to a treatment bed, but some of them to a fast track area separately and discharged from there. The intervention focused on the triage and the fast track processes, but we'll come to that in a bit. So then we got our data. We collected data from patient visits, gathered in aggregate at the end of the day, and status reports that were gathered routinely as part of care. That didn't cover all the sub-processes we wanted, so we used direct observation. We had people with stopwatches clocking how long it took to get people through the triage process, through the fast track process, and so on. And then we calculated the probabilities just based on historical data of what the chances were for all to end up going to fast track or to a treatment bed, for instance. And then we built the model. Using AnyLogic, we validated it in the phases that I described. We did face validation by keeping ED staff involved every step of the way and saying, is this what it looks like you do? Is this what it looks like you do? Internal validation, as I described, using a test data set. Not included in the final analysis, and then external validation because we did go through and perform the intervention, and that became our major outcome of interest for this study. Sort of studies. So again, here's our before system on the left, and here's our after on the right. It looks like a lot of pieces moving, but there's really only 5 or 6 steps on each model, and the only thing that changes are here. So whereas if you were registered, if you made it to the triage area, you were registered and triaged and then maybe sent to a fast track and discharged from there. We did away with the fast track entirely. And instead, if you were registered in the triage area, you may be seen by a mid-level and a nurse on the right. You may be seen by an MD, an attending, and a nurse on the left if you were a slightly higher acuity. And again, the very higher acuities, the ESI 1s and 2s, they were taken directly to beds. They were not put through a lengthy triage process. Or a registration process. Based on that, they may be able to be treated and discharged directly from the triage area. So it's being used more than just traditional triage, but in that same physical area. Or they were sent to a treatment bed and treated like everybody else. And here's our results. After implementing that actual change in triage and the whole department, we compared our before-after results with in the sim versus those with the real world. And here's what we found. The simulated percentage of patients whose length of stay was greater than 6 hours decreased from 19% to 13.1%. In the real world, when we performed it, that percent length of stay had climbed already to 19.9%, but we had a similar absolute decrease in those patients to 14.3%. So whereas it went down by an absolute 5.9% in the sim, it was 5.6% in the real world. When we looked at the mean length of stay as a kind of secondary outcome, the mean length of stay decreased from 249 to 200 minutes before and after within the simulation. In the real world, it decreased from 247 to 210. So pretty close. You can decide whether you think that that difference matters to you, and there's no statistic in the world that's going to tell you that, but for our purposes, that seemed like a good indication that our model was onto something. All right, now a little less biased approach. Here's an article that I had nothing to do with. For time purposes, I'm going to go relatively quickly here. But what they did is they were at a tertiary care center whose cardiology unit alone had 73 beds, including 26 ICU beds, also 4 cath labs, 2 EP labs, an OR, and a large tele unit. Also a 45-bed ED, which was involved in this process as well. And this study arose out of concerns for a policy that they had where every patient going for an elective cath as an outpatient had a tele bed held so that they could be returned to that tele bed in case they needed it. But in real life, 70% of those patients were being discharged. They never needed that tele bed in the first place. So they were reserving those beds, and they perceived that as a block on ED beds. So the questions they asked were, how do cardiology admission times from the cath lab influence ED boarding times? We're going to gloss over that question for this is, what was the expected impact on the length of stay of addition of different resources? They looked at a number of things, but we're going to focus on 2 of them where they looked at putting their catheterizations towards the morning, and which is before when the AD would typically need them, and adding beds to the cath lab, just as examples. So they defined their process, and here's what the system is they look like. And I'll try and illustrate the problem of ED patient block. So here's their cardiology division, including their cardiovascular ICU and tele unit. That interacts with other areas which are shared by cardiology, but other departments as well, including the OR and the PACU, which they treated as one unit for this simulation. The emergency department, where patients might return. So the problem that they identified was this. Patients might be going from the tele unit to the cath lab, or directly to the cath lab from outside. The idea was that they may be going back to the tele unit, and therefore they were reserving beds, and that was creating a block for patients who otherwise would need them in the ED. But what was really happening is a lot of those patients were being discharged, but they didn't change their policy to reserve their beds, so they still had a block on ED patients. So a lot of different pieces in this, but you can see that the problem itself was fairly straightforward here. So what they did next was they gathered data, fit their distributions. They pulled data from their EMR, collected over a year. They validated and constructed and validated a model. They used boarding time defined as a survival analysis problem using Cox proportional hazards regression, so a very rigorous method of defining their boarding times. And they used MATLAB and MEDModel to generate their distributions and the model itself. And then they built the model and validated it. And so here's an example of that model validation. They looked at what the real systems median times were, ICU, et cetera, number of arrivals per week, I should say, and what the simulated median was, which was generated by probabilities and not by raw numbers. And you can see that those numbers match pretty closely. This is the p-value for the comparison between them. And you would expect that if these were very different, statistically significantly different, that you would get p-values less than 0.05. But these are all well over 0.05, meaning that these are pretty similar. There are more precise ways of doing this, but this was a good demonstration. Here's a better demonstration. They showed what their process time distributions looked like. Here's what the real distribution looked like, and here's what the simulated distribution is. And you can see that those match pretty closely. So this passes the sniff test. And by reporting these graphs, the reader can make that judgment. Finally, they ran the experiments and analyzed their performance. And here's what they found. So this particular experiment was seeing what happens if we try to squeeze a couple of more cath patients before noon. Just make them happen earlier. Well, if you look at the effect on ED boarding hours, and that was their goal, you can see that it shaved off something like 45 minutes off of their boarding time. If they added a second patient in the morning, same thing happened. And then you start to get diminishing returns. But this model told them where the break point is. It said that you're going to get the most bang for your buck by squeezing 2 more patients before noon. They also did an experiment where they said, well, what happens if we add 3 telebeds? And of course, that's super easy in the model. You just add those. And you can see that adding 3 extra beds would shave off, again, 45 minutes of time. And adding 3 more beds and 3 more and 3 more beds could help, but not as much. Again, you have diminishing returns. So what's the point here? The point's this. If you're looking at an intervention to try and shave off boarding hours of these particular patients, then you've just said that you would get the same effect by putting a patient or 2 earlier in the day, as opposed to adding 3 more beds to your cardiology unit, which is going to take a lot of resources and money to do. If you're an administrator, which of those changes do you think you're going to approve? It's much easier as a process to just squeeze an extra couple of cases in the morning. And this really speaks to that. This gives you something actionable. And because their model was general enough, it's the sort of thing that you could consider whether it applies. All right, I've gone just about over time here, so I'm going to cruise past some of the limitations which I've mentioned along the way. There's the limitation of expressive power. The more detail you have in your model, the less generalizable it might be. I mentioned before that I wrote what would probably be considered an excessively detailed model because I'm trying to come out on the other side of this curve. That's my personal belief, but I'm not sure it's been done before. So let's just say this. In general, the more detail that you have in your model, the less generalizable it may be to another department. You may have something that works very well for you, doesn't apply to anyone else. It's also kind of a common mantra in modeling that all models are wrong, but some are useful. And that speaks to the garbage in, garbage out problem. You've got to have a model that accurately represents your process because otherwise, and represents the pieces that are important, because otherwise you're not going to have anything usable out of your model. It's going to be put together wrong, or it's just not going to solve the right problem. There's a learning curve for designing and implementing these things. It takes a lot to learn the software. In general, you're going to want to use proprietary software to help with that, but some people do from scratch implementation. That's tough to do. And there's a big time gap involved between publishing, the time you read a published trial, build the model, get your results, and then if you're going to actually perform years. So this is kind of a pun. There is a learning curve to learning curves, and understanding your data distributions is important so that you don't accidentally use a data distribution in your model that yields impossible results. So some of these curves may have negative values, and negative process times don't make sense. So you may need to exclude those. But more importantly, you should understand what these data distributions refer to and why they may or may not apply to your set. And then this speaks to the chasm, the gap between the time that it takes to your clinic, your department, your system, and the time that it takes to actually apply to your department. There's a lot to, it takes a lot of, and so this thing is going to take some time initially, but then things speed up considerably. Once you have a model, you can use that model. So to sum up, discrete event simulation is a powerful tool for describing complex systems and has been shown useful for modeling patient flow in a number of settings for a number of reasons. You do need to understand your data, you do need to understand your processes, and you do need to have the appropriate resources to do the job. But in the end, it can answer questions that simpler methods, queuing theory, and regression simply cannot. And in short, it can provide you the evidence you need to support the decisions that you have to make while managing your department. I want to thank some people without whom this talk would not have happened. Dr. Warden, Dr. Hoot really assembled a lot of the material for this lecture, which is drawn from something we gave at the Society for Academic Emergency Medicine last month. Dr. Day is a longtime friend and colleague who also has been instrumental in my understanding of DES, and a lot of what contributed to the content of this lecture. I may have written the slides, but he helped me understand it. So with that, I want to see if there are any questions.
Eric, thank you so much for your very nice presentation. Can I just ask a question before others? Hello, Eric?
Yes, hello. I'm here. Yes, please do.
Yeah. Okay. So you mentioned about the different approach, healthcare and and versus engineering approach. Why do you think the healthcare is very slow to adopt this approach, and it's been useful in other industries for many years?
Sure. Well, I mean, I think in part it's a symptom of the larger issue is that healthcare is a slow to adopt technology in general. You need to only look at electronic health records and how it literally took an act of Congress to get us operating together and get us to use records that work together. When I was a grad student starting out in 1996, I was starting work in medical informatics, but wasn't able to continue because they simply didn't have the resources in the university where I was. And I made the decision to put things aside and come back to it after my graduate studies and after my emergency medicine training and kind of catch up at that point. And I was chagrined to find that things had not progressed very much at all. I don't think most people walk away from a discipline and come back deliberately after 10, 15 years, but I did, and that's exactly what I saw. And I think that's permeated healthcare. So I think we're really slow to recognize the ability of information technology as a whole. I also think that, and I kind of mentioned this in my talk too, I think one of the big and appropriate criticisms lodged at the use of DES by administrators who are new to systems engineering is, how do I trust it? How do I know that it makes sense? It's easy to make blips on a screen. It's easy to make things happen, visually, and it can be compelling, but how do you believe it? And I think that's fair to say. It has to be a proven technology to work, and it's been more proven in other disciplines. And some of that is that we're slow to adopt and slow to believe, but also that we don't take the next step and see how accurate our model was. Knowing the limits of accuracy of a model are very important. It doesn't have to be 100% accurate, 100% precise, but you need to understand how accurate you can expect it to be in the real world to know if the intervention you've chosen is logical. And until we do that, and until we have a good body of literature that does that, I think we're going to run against that hurdle quite a bit.
Thank you very much. I think you touch on great points, because the adoption for the healthcare information system really can help in facilitate this transformation, how to using data-driven approach to make a strategic decision making, especially for those large-scale implantation, for example, how to train the workflow for ED, ICU, ORs, or the resources allocations. This is much more relevant, in this healthcare environment, to how to reduce the cost without compromising quality. And the other thing I think also the touch point, really the collaboration between healthcare professionals and also engineering communities. Really, that's really helpful to advance, because we both have the knowledge gaps, when we don't know much those tools, during our healthcare medical training, and also when the healthcare went to try to utilize resources, technology from other industries. So I think engineering, also we can learn each other. They can learn how to know the complexity of healthcare political issues, and also the challenging we have. For example, the data issues. The return on investment considerations, and so on and so forth. Any comments on that, Adam?
Mm-hmm. While we're waiting for comments, I will say one thing about that, because I think one of the things that DES has the capability of doing, by virtue of the fact that it has a visual interface and is otherwise more accessible maybe than statistical models, is it lets you, and also by the nature of how it's constructed, you can have different pieces of a system match up. You can build a model of one department that interacts with a model of another department. They have to be built, on the same sort of backbone, same software, and probably by the same modeler. But that sort of thing is possible. And so you can see how a change in one part of a system is going to change another part of it, for better, for worse, or for otherwise. And so I think that's something that's very powerful for DES, has a lot of potential.
Okay, So I think I didn't see any comments from the Google Hangout side. Any question from the audience on YouTube? You can post on the question on that the comments line, so we are watching that. Or you can call the Uber conference line, see if any questions.
Also, if there are no comments at this time, this talk will still be available on YouTube later. I'll certainly look to see if other comments appear, and so we can have an offline conversation.
Okay, if that's the case, let's just wrap up this session. Thank you, Eric, very much, and we are looking forward to learn more your study in the future. And then for the audience on the YouTube channel, and please follow up with us online. And we have a monthly session coming up next month, and in the next couple months. So we are looking forward to interact with you again. Thank you.
Thank you so much.
Bye bye.